The next session is basically echo imaging congenital heart disease. We'll have a talk by Dr. Kapur, K. Kapur from New Delhi, and our colleague from Apollo Hospital, and he has been working and associated with IECR almost since 2008. We'll have a recorded talk of OCT, IVUS, and coronary angiography, and then a small recorded talk about ASG closure. So these things will be discussed in this session. So let me have a privilege of inviting Dr. K. Kapur to start his talk, coronary artery disease and echo. It's very important actually. No, we have to have Dr. Kapur talk first. And this is in relation to echocardiography, which is an important tool. Imaging has improved a lot during the last so many years. And ever since I did the DM, there have been major changes and progress by echo. And echo is so important that not only cardiac patient, but even non-cardiac patient, we have to have an echo diagnosis before we go. So we can diagnose valvular heart disease, we can diagnose rheumatic valvular or congenital. But today the topic is, can we have some assessment of coronary artery disease by echo? Dr. Kapur is a very, very important echocardiographer, very huge experience, and huge experience of teaching also. He was in Paris and Amsterdam also in our conferences. So I really appreciate that he could come despite his small back problem, that he could come and give the talk during this ICR. Dr. Kapur, please.
Thank you very much, Dr. Vivek Gupta. Hello. Thank you very much. And I would like to speak on the non-invasive assessment of CAD. And by basically echocardiography. Now the non-invasive diagnosis, actually, it represents a major challenge for the cardiologist. And basically on the echo and exercise echo, we are able to detect a coronary artery disease basically by a wall motion abnormality, which is a marker of myocardial ischemia. Recently, we have some associated techniques like strain, myocardial strain, which we can actually assess on echocardiography. And on that, we can get a quantitative aspect of LV wall motion. So we'll come to this, that how echocardiography diagnoses coronary artery disease. So if you see to my extreme left, you have a normal wall motion. So initially, even when the patient is having pain, there may not be a wall motion abnormality, but there may be only a perfusion abnormality, which you can sometimes diagnose on contrast echo. Then you get assessment of diastolic function. That E and A waves that you're seeing, that is the diastolic function that we are looking at. And then we are looking at that before the actual wall motion abnormality is seen, sometimes we can use strain if we have that facility. Then you look at wall motion abnormality, actual wall motion abnormality, and after that ECG changes occur. So actually the wall motion abnormalities occur before the ECG findings. That is very important. That ECG may be normal, patient may be having chest pain or patient may not be having chest pain. The wall motion may be normal, but there may be a wall motion abnormality even when the ECG is normal. And then we can get, of course, echocardiographic findings of this myocardial infarction, which you would not like the patient to go into. You would like the patient to be diagnosed much earlier. So why do we need stress actually? That why cannot we diagnose only on the resting wall motion? Because if the lumen is occluded by 50 to 75%, there is no wall motion abnormality in the resting condition. Wall motion abnormality in the resting condition occurs only when the coronary obstruction is more than 90%. But if it is 50 to 75% occluded, then in that case, what we find, we can use stress. and stress-induced wall motion abnormality that can be uncovered even if it is just, even if the obstruction is 50 to 70% rather than 90%. Now, these are the examples of stress echocardiography compared with other diagnostic techniques, some of which are very expensive. You have the nuclear techniques, you have the MRI techniques, and in all those, if you look at the arrows for the sensitivity and specificity, the echocardiography, exercise echo, it stands very tall as compared to the other diagnostic investigations. Now, if you take the sensitivity of the various techniques, the exercise ECG has a sensitivity of only 68%, while the exercise echo has a sensitivity of 85%. And if you look at the more expensive techniques, the more advanced techniques like MRI, perfusion stress, that is 90%. So it's almost very close to the MRI, and the dobutamine stress echo also has a very high sensitivity. And the exercise echo is a superior technique in many ways. It can be performed at the bedside in the CCU or in the OT, and it's a fairly robust technique, especially if you look at the technical advantages that have occurred later on. It is cost effective, it is accurate, it can be done pre-intervention or post-intervention. Then you can use the innovative technique that have come up, like I said about the strain techniques, and you can use sometimes a myocardial contrast echo. And we have got now a large body of database is available showing the superiority of stress echocardiography in the diagnosis of ischemic heart disease. Now, this is how basically we divide the ventricle into basal. You can divide the ventricle into basal, mid, and apical, and you can make a pie diagram, as you can see over here, which is called the bullseye. And the outer segments, the most outer segments that are there, those are the basal segments. And then you have the mid areas, which are the mid segments. Then you have the apical segments, and right in the middle is the apex itself. So this is how we divide the ventricle into the various parts as basal, mid, and apical. And over there also we can find out which areas are perfused by the LAD, which are by the LCX, and which are by the RCA. So if you look at the areas which are in the apical segments and in the anterior segments, those areas are by LAD. If you look at the inferior segments, especially segment 5 and 6, now those are the inferior wall segments. And then you look at the lateral wall, that is segment number 8, that you can see that is the lateral wall. And I'll be showing it over here. You have the LAD, you have the RCA, and you have the LCX. So you can get the coronary artery territory, you can find out which region of the echocardiogram that you're getting is supplied by which coronary artery, and whether that wall segment is moving well or not. So in this case also, the blue ones, they are the RCA, the red ones are the LAD, and then you have got the LCX, and you can see that these are the regions that are supplied. Then you have also here over here, you can see that the red one is LAD, yellow one is LCX, and the green ones, they are the RCA. So how do we do it? In the pre-exercise, we'll take the parasternal view. Hello, yeah, we will take in the pre-exercise echo, we'll take the parasternal view and the apical views, and these are marked out, and then we look at the regional and global LV function, and look at the wall motion and calculate the wall motion score index, the percentage of the normal myocardium, and then we subject the patient to a stress protocol, which may be a TMT, which may be bicycle, or which may be a chemical like dobutamine stress echo. Now this is the bicycle probe, and you can see that we can see at rest and at peak. So if you look at peak exercise, the apex is not moving well. There is apical dyskinesis. So here itself we can say that there is involvement of the LAD, that we are taken on stress. There is involvement of the LAD, which we can diagnose by the wall motion abnormality. So how do you diagnose a new regional wall motion abnormality or a worsening of the pre-existing LV wall motion abnormality, abnormal regional function, decrease in the LV ejection fraction or failure to increase the LV ejection fraction by 5%, inducement or worsening of myocardial of MR, that is this mitral regurgitation, and LV diastolic dysfunction induced by stress. Now this you can see is the echocardiogram in the two-chamber, and you can see that the basal inferior wall is dyskinetic, that is RCA, and in the four-chamber you can see that the lateral wall is not moving, that is LCX, and then you get apical dyskinesis, that is LAD. So this is how we can diagnose which areas are involved. Again, you can see that you start with RCA here, that is the basal inferior, and then we look at the four-chamber view, and we can get the LV anterolateral wall, which is the circumflex territory, and the LAD territory is the apex that you can see over here very clearly. So we look at the wall motion by looking at the wall thickening. So if the wall thickening, this is in end diastole on my left, then you get in end systole. So if you get hyperkinesis, it's an excessive thickening, like is there in this picture number 2. In picture number 3, you have got a normal thickening. So the wall thickness generally increases by 40% or more. And on the right, extreme right, on the top corner, we have got the decreased wall thickness on the side of the lateral wall. So that is decreased, so you know that there is a problem there. Then in the first picture, or down on the left, that area is not thickening at all, so it is akinetic. And then you get an outward motion which is dyskinetic, and then there is aneurysm, which is actually a scar plus dyskinesis. Now this is as you see on echo. On my left is the pre-exercise, and on my right is the immediate post-exercise. So we have to be good at getting good quality images in the first 30 to 40 seconds after the exercise is terminated. So you can see that in the immediate post-exercise, the apex is not moving, as is shown by the arrows. So there is involvement of the LAD. And in this particular case, again, the apex during the exercise is not moving well as compared to the pre-exercise, and the LV inferior wall is also involved, indicating RCA involvement also. So again, you can see that there is involvement of the LV apex, both in the pre-exercise, which increases after exercise. So you can see over there, and now we can see, or based on the wall motion, we can color code it and see that which areas are involved. And you can see that the pink areas are the ones where there is a wall motion abnormality. So one is the purple area and the pink area. So that is LAD and RCA are being shown over here. And you can see on 3D stress, on the left, before intervention, before angioplasty, you can see that there is a wall motion abnormality in the inferior wall. And after the angioplasty, there is a good increase in the wall motion. So when you look at the bullseye again, you can see again that you have the RCA involved and you have the LAD, you have the LCX shown very clearly. Of course, there are so many technical factors that it depends upon the expertise and experience of the operator. It depends upon the image quality, and we have to see whether the echo window is good or not. So there are so many technical factors that affect the quality of the stress echo. So we can, certain refinements have come. There have been certain refinements that have occurred, like introduction of speckle stress, contrast echo, and 3D stress echo. So this is actually looking at the curved M mode, which is ECG gated and color coded. And you can get over here what is called the post-systolic thickening. That is, the thickening is occurring in diastole, which means it is delayed. Rather than occurring in systole, it is occurring in diastole. So that is called post-systolic thickening. And this is using the stress speckle imaging. So you can see over here that the strain is very good. It is 19.2%. And in the right-hand picture, the strain is markedly
request Dr. Kundu to be on the
reduced.
stage, please.
6.9%. Yeah, I'm just about to finish. So you can go here. Again, you can see that there is, in this particular case, you're getting inducible ischemia in the LAD and LCX. Again, you can see that the speckle strain, you can see the involvement of the LV apex, and especially using the VVI, you can see the arrows, and you can see the wall motion abnormalities. And this is the contrast echo. So we are using the contrast echo over here, and you can see the black areas at the apex after stress. Those black areas indicate areas of hypo, that is the less blood supply. So areas of apical hypoperfusion are seen at peak stress. Those are the black areas that is seen at peak stress. And then you can see that the proximal inferior, this is the black area that is seen. You can see on the right-hand corner after exercise that there is a lot of black areas indicating RCA involvement. And this is, of course, using a different technique altogether, using dobutamine stress MRI. And you can see the excellent quality pictures that can be seen. But it is hardly done. To do MRI itself on the heart is not easily available, as well as to do a stress MRI using dobutamine is also a lot of problematic. But you can see the quality of the pictures if possible. And these are the nuclear testing. So you can see a good nuclear perfusion in the resting condition. Then on stress, you can see that the anterior wall is not moving. The anterior wall is not moving on stress, indicating that there is LAD involvement. Thank you very much.
There is no doubt that
Vivek, a question.
yeah, we heavily depend upon echo many times pre-surgery, during anesthesia checkup, and many times we miss out also. But let Dr. Chhabra have a question and comment.
Dr. Kapur, if TMT patient has come to us for the PAC, and TMT is positive and stress echo is negative, how will you diagnose whether it is really a false negative or?
See, there are two possibilities.
Yeah.
One is that there can be LVH, and that can produce ST segment changes on exercise, and that will produce a positive TMT.
No, echo is normal,
Huh?
no LVH.
So echo is normal. No? There is no wall motion abnormality.
Yes, no normal.
So no wall motion abnormality, meaning that the coronaries are likely to be normal, but we are getting a positive ECG based on left ventricular hypertrophy.
Okay.
Because in the left ventricular hypertrophy, you get a relative ischemia. Because there is hypertrophy, so which means there is a relatively less blood supply, and that on the ECG comes as ST segment down.
Could it be a false negative?
So ST segment negative, the ST segment is there.
Yeah.
This is called false positive.
Okay, false.
The TMT is false positive, echo is okay.
Okay, thank you.
But another possibility is there that your echocardiography has not been done well. That is also there.
Yeah.
So it has to be done by an expert.
Expert, like you.
Priya Mishra.
Any question from the audience?
Indo-European.
Any question from the audience? If there is no question, then hand over to Dr. Vivek. Dr. Vivek?
I start, actually we have a recorded talk. I was just wondering and asking Dr. Kapur, because many times, because I have been working here since along with him, many times stress echo is negative. And despite that, when we do angiogram, for some reasons, and we have a critical disease. So is it because of sensitivity is about 85%?
Yeah, first is the sensitivity is actually 85%. So out of every 100 patients, there will be 10 to 15 patients. Out of every 100 patients, there will be 10 to 15 patients who will show no wall motion abnormality, but will have a coronary artery lesions.
So that means the crux is that, of course, stress echo can diagnose in most of the cases, but again, if you have a clinical history suggestive of old MI or something like that, and if you are undertaking a very serious surgery or long general CCR, many times, especially in a patient with CKD also and going for something very important, so many times we do actually coronary angiography other than stress echo. But because we have seen many patients, it's actually truth, and all the doctors are listening here, that we have had catastrophe in a patient who is actually having a past history of CAD and stress echo negative, and we did surgery, anesthesia, and we have had some problems. So we have to be very careful in analyzing. But of course, in a normal patient, I would say that in most of the peripheral centers, Dr. Kapur and Dr. Chhabra and Dr. Kundu will agree, many times they do just do ECG and not even echo. I'm talking of pre-anesthesia or pre-surgery checkup. So I will advise all the people sitting here, because we have to learn that these patients, at least we should do stress echo, whosoever is having some risk factor like diabetes, hypertension, before giving general anesthesia, then of course you will be much more safer. And also documentary requirement is that just regular echo is not important, is not enough. Thank you very much. So we go ahead with our next talk. Please stay here. Very important talk, which is a recorded talk. Our friend Dr. Greg Stone, he is a very important cardiologist from New York, working in the US, and TCT director, and with his kind permission, I'm using one of his videos, and he has sent the video, which he recorded, because 30th December he could have come live, but it's for the Americans or for US, this is already a holiday period. In India, we don't take we take normally less holidays as compared to those people. I think they are more privileged. So let me start this talk, because we're already a little late.
Greg Stone. I'm a professor of medicine and population health sciences and policy, and the director of academic affairs at the Mount Sinai Heart Health System in New York.
The topic is angiography, OCT,
Well, you know,
OCT
there've
versus
been,
IVUS in
numerous
coronary angiography.
studies
This is
and
a new
numerous
thing, of
meta-analysis
course, for
done
everybody
in
here.
past of
But we
intravascular
should know
imaging
something about
versus
everything.
angio.
Whatever advancement is happening, we should know. That's the purpose of this